Good afternoon, friends. Thanks to Care Group and AIS for giving me opportunity to share my experience on Eyemax Mono. Though they were recommended as Eyemax Mono is a hope for ARMD, but I would say it's not only hope for ARMD, but also for non-ARMD patients. No financial interest in any product shown here. IOL AMD or Eyemax Mono IOL is a unique approach for extending and improving the visual function in a patient with maculopathy for various reasons, not only for AMD. So what options we have currently for all these macular scar? So we had previously Prism, which we can put in the glasses. We had similar implants in the past like IOL VIP or Revolution or IOL AMD. There were dedicated low vision aid glasses in terms of external visual aids or the different implants which are available. These are the few of the pictures which are currently available internationally about the telescopic IOL. Though the previous one and this is the current one. The old IOL, the telescopic IOL are the very big, bulky and is very difficult to put. There are a lot of other pros and cons for that lenses, and this is the current IOL AMD or Eyemax Mono what we have. These are another lenses which is currently available in the market, and all these lenses basically have some telescopic effect or maybe the little decentration, but then the procedure itself is very tedious to do it, and it's very difficult to convince patient about these lenses. We had a previous version of this AMD lenses, that is a Hubble IOL, which is a combination of two lenses, that is a minus and the plus, but again it has a little different procedure to operate. Now currently what we have is Eyemax Mono, jointly developed by LEH Pharma, Dr. Pablo, and the manufactured by Care Group in India. I was behind this telescopic technology for last 4-5 years and currently working on that. We had this evaluation history starting from 2006 when Dr. Bobby Qureshi had done a first implant, and then currently in 2016, and then followed by now 2019. So what is Eyemax Mono? It's a combination of two lenses, which is a combination of minus and the plus. It's a small incision. It works like a small hydrophobic acrylic lens now, implanted in the capsular bag, and it has a very advanced optic in terms of wavefront optimized and super aspheric design, which gives not only magnification, that is a telescopic effect, but it decenters your image to a preferred retinal location by at least 10 degrees. So it is put in the capsular bag. It's a proprietary their design. They don't disclose the design, and really I don't know what is actually in the design, but what I understand is hyper wavefront modified, and it decenters your image by 10 degrees. It gives a magnification of around 0 to 220 degrees, that is around 1.2x. So what we understand from our optics, which at the fovea we have crisp clear vision, and the surrounding parafoveal area where the vision is relatively less. And all these macular disorders patients in the fovea will have very clear vision, but on the periphery once you go from 20-30 degree vision will keep on going down. Now because of their central scar, they are not able to see in the center, and that's what we have to have is a parafoveal, the vision stimulation which we have to do. So what is the standard monofocal IOL which will be giving vision only in the center part, but the surrounding area will not be utilized. So what we get in the standard monofocal IOL is only the central vision, while the parafoveal area what we are getting now in the Eyemax Mono is what I am stimulating is a parafocal area. So similarly, there are a lot of questions in the previous talk where, not here, but other session where you can use a simple prism and get the same type of vision. But only prism will give PRL, that is a preferred retinal location at only one particular point. It will not work on all the areas. While Eyemax Mono works in the entire area, that is around 10 degrees in a diffuse way. So we really don't know which is the area which is healthy and which is the area which is unhealthy where we can actually stimulate. So what is getting in Eyemax Mono is stimulating the vision in the parafoveal area. So we are basically working on the stimulating the image on the parafoveal area and magnifying the image. And with glasses for distance and near, it still works. It gives little better magnification with +3 glasses when we use post-op. So these are different magnification what we are getting from Eyemax in the distance and the near. I'll go with the indications what I have currently used. That's the dry and scar ARMD, the macular dystrophy, the best disease, macular scar due to other causes, and myopic macular atrophy. There were the initial criteria for AMD patients, which I have slightly modified for my criteria. What we do is a vision uncorrected and the best corrected vision, vision with the glasses. We use a various types of telescope as a low vision aids, color and contrast vision, fundus and the OCT. The visual which is the most critical, and the trial of low vision aids and the alternate patching for both the eyes for at least first 3 months. Patients should understand it's not something magic what we are doing. They already have a bad retina, they don't have a central vision, and we are getting something for the parafoveal areas to work. But they has to understand what is that parafoveal area and how I can see from the side. These are the patient suitability lens chart what AIOC people provides. These are the few cases which I have done. My first patient, yes, it was a dry ARMD which got backfired. I have not put their photographs, and then we just lens came and we had put, and then there was actually the retina got, there was a swelling on the retina which actually got backfired. But these are the other cases which I'll show. These are the Stargardt's macular dystrophy patient. These are the first two which I did bilateral. These are their initial OCT pictures. The first patient we could not do perimetry because which I didn't realize in the initially we just had OCT and fundus pictures. For me, the critical part is the initial low vision trial. So my optometrist does a very good job about giving the telescope. We make them to patch one eye and see with the other eye alternately at home, and then we make them to use this low vision. There is a telescope. What we have seen is with Eyemax mono, which is 1.2x, it works equivalent to around 3x telescope currently. Though patient get better vision with 6x or 9x, but what currently which is getting a 3x telescope is almost equivalent to what I am getting in the Eyemax mono lens. So these are the different telescopes which are available in the market. You can show different types of telescope to the patient. And then actually they see with each eye and see how much is the stimulating. In my practice, I have seen binocularly when it works better. The basic concept, it has to focus on the peripheral 10 degree and binocular. Both the eyes has to work together. So this is the first patient. The initial vision was hardly 3 feet, and then post-op he has improved to almost 618, 612. They are very happy family with their, came from the village, and practically this boy was not working, and then it started now his routine work, it started driving also.
Can you summarize please?
Yeah, it's time. These are the other case, the Stargardt macular dystrophy, the other lady which I have done. I would like to show the perimetry part. There is a pre-op, before surgery, and the post-op. They actually shift their preferred location, and you can actually see the magnified and the field of vision also enhancing after the surgery. This is the third patient, large macular chorioretinal scar post-choroiditis, and even this patient had worked very well. This is a pre-op, and that's a, and this is the last patient now which I have to just operate. He is still undergoing the LVA trial, and probably in next month I am going to operate this patient. The surgery remains a standard like a normal cataract surgery. You don't have to do anything fancy for the cataract surgery. It just just a standard of hydrophobic acrylic oil. What other? Thank you for a kind attention. Thank you.